So hi, I'm Jordan Goldsmith. I'm with DataSmart. This is Bernard Khomenko, also with DataSmart. So we're going to go through the presentation, but we're totally open to just kind of open conversation or questions you guys have. Fairly informal presentation. So, and we're based here in Montech, so we just had to walk across the DataSmart Solutions.
I thought you were in Helena.
We have an office both in Helena and here in Missoula.
We're international, actually.
Would you want to click for me?
Yeah.
All right.
Go ahead.
Okay, so I was just recently, can everybody see that? Is that focus? Okay. Little. There we go. Okay. So I was a member of the Big Data Alliance. It's kind of an organization that was created by the Montana Economic Partnership and also the Montana Associated Technology Roundtable, as well as GCS and Alex Phelps. So they came to us about a month ago, and I was in the meeting that we were having, and they said, oh, we're working on putting together this Big Data Week. You know, we're still trying to get it, and Caitlin and Russ are working on it. And we're hoping that Missoula will be part of Big Data Week. And they go, but we don't have anything lined up. We have no presenters. We don't know what's going on. So they said, do you have any ideas? And I was like, oh, you know, we could maybe give you guys some information on healthcare, or if it coincided with First Friday, we could do some like infographic stuff. Could be cool. And that was about it. And then I get an email from Melanie Brock from MEP. About 2 weeks later, and she says, oh, that sounds great, Jordan, we'll sign you up for your presentation. I was like, well, not sure I was signing myself up, but that's what you get for going to the Big Data Alliance. So we came today to talk about who our company is, kind of what we do, and the industry that we're involved in, and a little bit about healthcare and how big data is changing the face of healthcare and where DataSmart Solutions is jumping into that. So what is big data in healthcare? If you were at the Big Data for Dummies yesterday with Russ Fletcher, he went over that, you know, big data is everywhere. You're being tracked in your cell phones. You're being tracked on your internet searches, your consumer purchasing history. Big data is this, all of this stuff is coming in. Very little of it's actually usable. It's difficult to put into a structured format. But for healthcare, we're looking at stuff specifically related to anything that happens in a hospital or through a medical claims, or more and more now electronic health records. People are also starting to connect to mobile fitness devices where they're measuring the steps they take or how much they are active in a day. So again, numerous data sources kind of coming in. So you want to take this, put it together, make it meaningful, and then hopefully on the end you come out with effective solutions to help manage people's healthcare and, you know, ideally reduce healthcare costs, injury, illness, things like that. So kind of an overview of, again, all of these sources that are coming in. There's been a big push recently to develop health information exchanges on a state level. Statewide is kind of part of the Affordable Care Act. So there's hospitals are coming in, labs, physicians, different hospitals, patients. So we're trying to get this all in a centralized area where it's, you know, then being something you can use and is meaningful. A big change in the healthcare landscape recently is the use of electronic health records. As you can see, in 2001, about 18% adoption in doctors' offices, to now it's a 78% adoption rate in physician offices. So these are software that can be cloud-based, can be mobile, used on a mobile device. can be accessed by both the patient and the doctor as well. So a lot of information available through these, but there's some issues. Next slide. And again, the change in kind of the face of the data economy is shifting. Previously, it was claims-based, so you wouldn't really know about somebody's health history or health issues until after they got a claim. And the whole claim system was really developed so that providers could get paid. It wasn't developed as a way of predicting somebody's health or issues that might be coming up. It was based upon how do we get paid for the services that we provide. So claims are a reactive kind of predictor of health care and healthcare cost, where these electronic health records, these are more clinical information based, and they are also something that's going to allow for a more proactive approach instead of a reactive approach, hopefully to be preventative in medicine instead of kind of reactive to something that's already happened. As I said, there's some issues though. If you look at the electronic health record systems, there's a bunch of different ones available. There's no mandate on which one you have to use, and less than 5% of these are fully interoperable with the data sources and data types that are coming in. So it's a challenge to bring all of this info in, which as people say, you know, big data, what are the issues? But we can say that you know, this is going to be one of the huge challenges of the decade, is getting electronic health record information integrated so that it can be analyzed and shared. Again, another kind of slide saying what are these sources of information. The internet is the #1 resource for health questions and concerns, a data source that's impossible to integrate right now. You know, it's an anonymous search. It's tagged to a person, but then that's anonymized. So we can't use that, but it's a source that if you're seeing somebody searching about, you know, a specific information, you could possibly be able to reach out to them and say, well, here's some more information you might need. Yesterday, Russ Fletcher mentioned that Target, they were looking at purchasing data from customers that were buying things related to being pregnant. And if a customer came into their store and was buying like these prenatal vitamins and maternity clothes, et cetera, they would then target that person with a specific advertisement for baby-related products. I guess they ended up getting in trouble with that because if it went to like a household where a daughter was pregnant and the father didn't know, then they're kind of spilled the beans. So, but these interesting sources, so Dr. Google is the #1 source out there. All right, so I'm going to pass it over to... Yeah, Dr. Google is good. So I'm going to pass it off to Bernard to get a little more in depth on how DataSmart does its analysis.
Thank you, Jordan. My name is Bernard Khomenko again, so very happy and excited to be able to share some of the work that we do, exciting work that we do at DataSmart. Just a couple of points that I think just to connect with what I'll be talking about to what Jordan had mentioned. One of the initial slides had talked about the big data and how it's applied in the healthcare. Just came back from a very large international conference sponsored by Johns Hopkins University, and I was very happy to learn that I'm not the only one who still doesn't know what the big data is. So it's like everybody's talking about it, but nobody really can identify what that is. But the big point there is 80% of the data that's being collected, it's not really useful. Well, it's not being used. It cannot be used because the way that it's stored. Also with the electronic health records, so that's kind of a new upcoming source of the information. If you remember, there was this tipping point that's going to happen just next probably 5 years or less, where there'll be a lot more electronic health records, EHRs as we call them. There are other terms: personal health records, electronic medical records, electronic health records. So, and some experts in the industry are trying to make, you know, the separation. I think that's all basically the same. It's your health records put in the electronic format. But the reliance and the importance of them is going to go up and up and up. But if you recall, it's only 5% of those collected data sources can be even exchanged. So even though with the new HIPAA rules, with the new healthcare reform actions and lots of money that the federal government has thrown into this area. Being able to exchange that data, so going from same paths to community, you likely still not have your medical records go along with you. So what some of the work that Data Smart does, of course, is we try to be smart with the data, as it comes from our name, but also we're looking specifically at the healthcare data. And the healthcare data, as Jordan had mentioned, for the longest time has been relying primarily on the claims information. And claims, the way that they're structured, collected, and then used primarily is for reimbursement of providers. They're not really designed to care much of the clinical data beyond just the need to get paid. So with more and more people that are entering healthcare system right now, thanks to the expanded coverage, and now everybody has to have a coverage or pay a penalty. Previously, people that have been uninsured, we're talking about millions of them, they're entering the healthcare system. Because we've been working with the data and looking specifically at how to predict those healthcare events, identify high costs that will be happening in the near future, not long term. So we don't care about Medicare, let's say, at this point. We're trying to save the health plans and identify the health costs in the next 12 to 6 months. But a lot of those future health high cost events, they're coming from people that really don't have any information. We don't have any information on them right now. And when I say a lot, it's about 60% of people. So we don't have much of the data, if any. And as I mentioned earlier, 80% of the information, so we have this conflict where we don't know much on this major group that are going to be costing a lot to healthcare system. At the same time, there is this pot that only 20% at the most of the data that's being used. So our goal in Data Smart is being able to to gap that bridge, or to bridge that gap, and then being able to mine the data to make a use out of it. So just to give you some examples of why it's important, let's talk about chronic illness. A lot of times chronic illness, people are talking about it after it's been diagnosed and or known to a healthcare provider. And it's no surprise that the chronic illness is a #1 leading cause of all healthcare expenditures. It becomes even worse when you have multiple comorbidities, and if they're chronic, so hypertension, diabetes, depression, so they all can come together. Then person can cost from, so the cost of the person can grow exponentially. This is just one of the examples. Somebody with hypertension, relatively low cost if it's only hypertension, but exponentially high cost. So 7, 8, 10 times more as you start adding additional healthcare cost or healthcare condition to hypertension. So again, just a little bit more stats. 83% of the spend goes for chronic health conditions. So this is just as an example. So at Data Smart, what we do, again, is that we collect the data, we analyze, and we help the companies to take actions on how to reduce their future healthcare costs. And when I say future, it's relatively short term, so over the next 6, 12, 24 months. So this is just as an example, and I guess I don't have a pointer, but kind of at the above layer, you see that we divided this. So when we get the data, we normally just divide the data and divide the population into different categories. So here we had stratified this group into risk cohorts. We call them resource utilization bands, or RUB. And what you can see is that in the RUB that identifies people with no or invalid data, you have a lot more people than you would normally see. And that's very, very typical. In fact, it's becoming to skew the benchmarks, so the national benchmarks, that they're actually getting updated too, because we don't consume healthcare, our data doesn't get exposed. So let's say quarter of the population, that's pretty typical, we don't know anything about, and that's over a whole year, so there is not a single record. And at the same time, you see a very high section of that graph where it says that this group is very, very high, above the expected, so almost twice in a very high risk. So what happens is that people don't go see healthcare, so they don't go see their doctors, they don't receive healthcare, but once they enter a lot of them immediately they shift to a very high risk group, so to a very high risk category. So this is very typical. We're looking for those patterns, and when we see it as we come into employers, to health plans, whomever that we're working with, and say, you know, if we knew something that will give us earlier indicators of why the person could be high risk, we can outreach to them and start making an impact. This is just some of this is a two-dimensional. We'll look at data in more dimensions, but this is kind of how we look at the data, looking at the national, so percent of the national benchmarks, also changes in prevalence rates. A lot of this is again done just on claims data, which is very standard to receive. It's relatively easy to obtain, but as we talked about, most of the people don't have very good clinical data. So imagine being able to look at this and try to make a decision, basically knowing in advance that the decision that you're making is not based on the full data. So you don't really, I mean, you're about just from the get-go, you're maybe 50% accurate. So, you know, trying to make a decision based on the information that you have. So a solution that DataSmart offers is to apply advanced analytics and start modeling and bringing in additional data feeds and data sources so you can be a lot more accurate. Basically, now you don't have data only on 50%, now you can have data on 90% of the people, right? So again, a lot more accuracy. The biggest hurdle in that, and kind of how it goes with the big data, as one of the opening slides was all these data channels that are coming in. How do you aggregate it? And our approach is to start working with the people, with the companies that actually aggregate healthcare data. So once we establish the connection, bringing the data in, storing it and linking it, that's actually is relatively simple. The first step, and I think we probably spend 60 to 70% of our time just outreaching to people, you know, being able to collect their data. So the process is very, very time consuming. That probably partially explains why only 80% of the data is used, or 80% of the data is not being used, only 20 is being used. It's really, really hard to obtain it. I don't know if they'll be surprised, but again, as I mentioned, now everybody talks about big data. Well, we've been working, kind of living in this big data world for a while. This was one of the studies that we've done with the local university. Very good outcomes. We did some, you know, couple publications, white papers, but again, we've been doing it for a long, long time. So I can tell you just from experience of doing that the big data will, you know, further will expand. We'll be living in it. It's just a matter of learning how to deal with it, how to work with it. Our advanced modeling and the work that we do, so once we collect the data, we actually have a research and development team, but what they do is that they apply statistical modeling to bring the data together and to find those correlations and associations that we wouldn't know otherwise about. So this is an example where we take, let's say, your future cost over the next 2, 3, 6 months, 2 years, 3 years, and we bring those other data feeds like vision data, not just to say you went and had a vision exam, but actual clinical markers that come from the vision exam. HRA, it's a health risk assessment, so your self-reported data. So I don't know if any of your employers where you work, if they've been asking you to take an HRA online. Just about every wellness company has one. Taking biometrics data. Lab data is very, very rich, so you can, from your blood reading, from your blood test, you can say a lot about a person. But now putting it all together, making sense out of it. So and that's what our research and development team does. And this is just as an example of some of the outcomes. If we take all those data sets and then start putting people into risk groups, so low would be 1, moderate risk 2, and a high risk 3, and then relating it and creating an association to risk scores and the costs that are affiliated, that are actually the medical costs and the pharmacy costs, you can see that the predictive power is about 4.5 times from assigning somebody to low risk to assigning somebody to high risk. So just some of the value that we show that we've been able to deliver to our clients. This is just as an example. It's designed to be confusing at first, but there is some rationing to this madness. So table, we're very like tables. So Jordan and I work with tables every day. This is very simple, actually. But what this one says, initially I showed you a slide that had divided people into the risk groups. So we would expect the way that the cost will behave is that people in, let's say, low risk will cost less than people in a high risk. Well, that's not always the case. So as you can see, adding additional data elements that are, let's say, grabbed from this big data set. In this example, it's a lab data. So adding that one variable to the overall picture of your healthcare risk, of your morbidity, can actually make a big, huge difference. So this is an example that's highlighted. So somebody in the resource utilization band, or think of it as a risk group that is designed as very high with a low lab reading, will cost only half of what a person in the moderate, so by default is expected to cost less. But with a very high lab reading, costs twice than what a person in the high risk. So in this, the applicability is, imagine that in all you have only limited resources to go and to start managing people, right? So you can refer them for disease management program, for case management program, if you identify somebody of high risk. So with this additional data elements, you can be a lot more accurate. And you can only send now people for appropriate intervention that are really needing it. So how the process works, we talked about chronic health conditions. They're mostly prevalent in the moderate and high risk groups. So the red bar, that's a group that we would measure, or a group of people, whomever, without adding additional data elements. And the green bar, that's with adding additional data elements. So you can see how the shift happened. As we talked about the underdiagnosed or people that we don't know anything about. So people had shifted from, let's say, being at 36.7%. Now they're up by about additional 5%. So those 5% are the people that we didn't know that they existed before, and they had chronic health conditions. So this is some of the exciting current work that DataSmart does. I work a lot with research institutes. I mentioned Johns Hopkins as being one of them. We also work very closely to the U of M, MSU, and other schools. But this is some of the current work is obtaining data, as I mentioned, that's probably some of the most difficult task. So our approach to that is that a lot of times you don't really need to have much of the data, you only need to have the right data. And we always go kind of after what's the cheapest way to obtain the data and get the most value out of it. So self-reported information is extremely, extremely valuable. So our work with Johns Hopkins University presently is to model, basically to ask those questions that are going to be self-reported, and they don't have to be long. Again, I don't know how many of you have taken health risk assessment just recently. The ones that I've seen go as high as 120 questions. Well, and it takes you 20, 30, 40 minutes to answer them, so not everybody wants to sit through it. Well, we've gotten down to about 12 questions. It takes you 5 to 7 minutes to answer, and the value of those 5 to 7 questions is as big, if not bigger, than those 120 questions. So that's our current work. And this is a little bit of a marketing, I guess. So we've been just recently featured in Predictive Modeling News. It's one of the biggest publications in a newsletter. So all the work that we do at DataSmart has been brought up nationally. And special thanks in helping us, of course, goes to Johns Hopkins University, some affiliate entities that are with them that are working very closely with us. So, questions? Yes.
Thanks for that talk. I have a couple different lines of questioning. So if other people want to jump in, they should. But the first one is just about what are the platforms that you develop on? What are the tools that you use?
Mm-hmm. Right. So we made a decision. Well, initial work has been a lot of it just done within Excel, in terms of being able to bring the data together, access, and then we're going back, 10, 15 years ago. Most recently, we switched primarily to SQL database to store the data. And then in terms of for modeling, we're using primarily SAS and R So R is one of the statistical tools. So our research and development team, they really like R. It's an open source. I think it was developed by guys out of Australia, because SAS, though it's being a wonderful tool, it's very pricey.
Yeah.
So those are the tools that kind of...
The other question was, so I have had to take one of those HRAs.
Oh.
And I guess, and so I'm wondering, so they report something back to me. What, I don't know what, if anything, they report back to the employer, but as an employer, what should I be asking for from the HRAs? Like when they're aggregating the results and individual follow-up with people?
Well, first of all, if you're from an employer position, you want to be very careful not to violate any privacy laws, medical leave, HIPAA primarily. So from an HRA, first of all, HRA is very, very, very valuable tool, but as we learn is most of the HRAs don't feed much of the data at the individual level to the employer, neither do employers want to know. So the things that you can ask are probably more from an aggregate point, how many people, basically from what you've assessed, can you tell me if I need to change either any policies, the personal leave, or do I need to update my benefits? A lot of the individual information can go to health plans. So then as an employer, you can have a self-funded health plan. Basically, you are the insurance company, or you can buy it, let's say, from a larger carriers. So a lot of times that information could or should be shared with the health plans, because health plans, looking at the information, they can make a decision who they need to outreach, who's at risk for maybe non-compliance with the medication, who's at risk for some high-risk, high-cost event in the near future. And that's the type of work that we do, for instance.
So we should, based on those HRAs, and they all come with a lab, we should be able to get predictive, like, claims information out of the vendor? Like they
you should be able to predict. If I go back for just a second, what one of our analysis, so you should be able to basically identify people, put them into low, moderate, high-risk groups, and be able to be very, very accurate in identifying those people that will cost you a lot of money in the near future. And then from that, if you have a knowledgeable team that can now manage those people, then you can then avoid those future those future costs. Those are very, very profound questions, kind of how to use the data, and then once you identify somebody, what to do now with it. Yeah. And every employer is asking the same question, and every health plan is asking the same question. And the historical approach is, let's wait for something to happen, and then we're going to try to manage it. Or even worse, we're going to shift the cost to a patient and say, all right, now you're responsible for 50% of that. So which is even worse as a consumer, as a patient.
So how many HRA organizations are there? I mean, people doing the surveys?
I think some of the national things or some of the national stats that we've seen, if wellness is offered, it's in about 70 to 80%. Again, HRA, like a health risk assessment, it's a very cheap way to.
But who does those?
Oh, who does those? National vendors. So every vendor has their own. Like Mayo Clinic would have their own. WebMD has their own. So a lot of them, they've acquired some other companies that had developed HRA. And the interesting point about an HRA. Kind of the wellness, and I guess I haven't been in the industry long enough to remember the 80s, but I was told that back in the 80s it was kind of went through the same type of cycle. Hey, let's implement wellness, we're going to cut the healthcare costs. But I've been in the industry long enough to remember in 2003, 4, and 5, wellness companies were popping up everywhere, and they're saying, if you do this wellness, this 5 things, your healthcare costs are going to go down by 30, 50, 60% over the next 5 years. Well, I don't think any of those came true. But what was happening, which was really interesting, is that a lot of the health risk assessments back then were based off of one single study that was produced by a university in Nebraska that was based on I think it was mortality predictions. so industry kind of jumped on this. It's public knowledge. All these questions were modeled to predicting basically your mortality rate, over the next 5 to 10 years, and then they started saying, well, that's going to be your wellness index, so, which didn't really work well. So.
But yeah, like locally, we work with a company called It Starts With Me, Health Promotions. So they're based here out of Missoula, and
That's a wonderful company.
Yeah,
right?
they run HRAs and will do lab assessments as well.
That's
All right, so now I got to see what you guys are supplying on the employers.
and that a company actually we work with for a very, very long time. Kind of have seen them, evolve from just screening a couple of employers. I mean, they're regional now, and they work with companies like State of Montana, Montana University System, many banks. So, very, very good company, definitely.
Sure.
Are you data mining EMR for this predictive modeling, or is it all just based off the HRAs? I think I might have missed that.
Mm-hmm. It's actually, it's based just off about any data point that we can bring in. So electronic medical record, when data is mineable, so if it's not just a scanned PDF image, which I think a lot of providers, a lot of doctors, they would call it an EMR. They just go and they write something and they just scan it through, right? But if it's mineable, if it's reportable, then we're going to work with it. So non-compliance markers, for some medications, readings of your blood pressure. So all those we roll in and we can analyze. In fact, just recently, I think as recent as today, we're working with on-site clinics company. And on-site clinics, they don't generate kind of a typical claim record, but they said, we can feed you a lot of clinical data, and they have markers like we didn't receive before. For instance, a marker for, is it a visit due to an injury? So like they just have a marker that says, yes, this was due to an injury. So if you know about the insurance, a lot of times insurances try to shift their risk, or who's going to be paying. Is it going to be a work comp claim? Is it going to be a health plan covered by an employer? So those things, they can really help us with what we do.
So, I'm sorry. No, go ahead. How do you have access to the data? I mean,
That's my question.
I mean, I don't have a clear picture of exactly, because presumably you don't have individual information.
We actually do.
You do.
Yes.
And how are you able to do that? What kind of clearance do you?
We work with health plans, and we comply with HIPAA rules as a primary privacy rule. So when we work with health plans, we essentially work on behalf of the health plans, helping them with management of the health plans, and HIPAA allows for certain reasons, so certain business reasons, to share personal health information with other entities. So we become that other entity in a privacy world. We're business associates, so we're all bound by the same rules. If there is any break-in, we have to notify. So it's no different than if you work with Blue Cross of Montana or United Healthcare.
Yeah, and I've actually had a bunch of people ask me this question as well. And I started working for DataSmart Solutions about 6 months ago, and I recently went to the doctor for an office visit, and they usually have you sign something that you don't usually read the full way through, but if you do read through it, it will say, I am consenting to the release of my data in that release that you are signing. So next time you go, read it through, and you will see in there where you actually will be consenting to the release. And most people have signed that release to be able to get on the health plan in the first place.
That's the only way it can be shared.
Yeah.
Within the HIPAA.
Yeah. And so a lot of people are kind of under this false impression that it's absolutely theirs, but it's like, well, no, you actually signed this release. And I was not aware of it myself until I kind of got into this world, and then I started reading them, and I said, oh, there it is. I mean, I'm releasing my data to somebody, I don't know who, but for me to get care at a hospital or even sign up for insurance, you're basically allowing that company to have access to your data and release it if they need to do analytics or something like that.
Essentially, if you're healthcare, if you want your healthcare to be covered by another entity, by an insurance company, then by default you're authorizing the claim. So you'd say you went and saw a doctor. Doctor's office will generate a claim to be processed and paid by an insurance company. So then that insurance company already has the right to that record, and then they also, let's say, they can contract with other entities to help them with managing of this cost. So we become that other entity that helps the insurance companies to manage the cost. You know, what's really interesting is that I think right now people are, with electronic medical records and health records and personal health records, they're more aware of being able to access their personal health records. I remember this is how industry had changed. It was actually a big eye-opener for a gentleman that was a wellness coordinator for one of the companies, to be unnamed, but he was very surprised that as a patient you can actually have access to your own personal health records or your own medical records. And I think it's something that was mind-boggling to me. As a patient, you should be able to see your own records, but he thought that that's not the case. So.
Yeah, and I would just add to that we take HIPAA and privacy very seriously, DataSmart, and we train everybody, you know, once a year on HIPAA compliance and HIPAA policy, and it's something that it's you know, on the top of our priorities. So.
Yeah, we don't want to be another target in the news. Yeah, definitely.
Yeah. I believe this guy had a question.
Well, geez, no, not that.
Okay.
So let me go to the one that's on the top of my head. So you mentioned at the beginning that your 2/3 of your work is getting data.
Correct.
So are you doing that on behalf of the insurance companies, or are you doing that independent of the insurance companies? You know, and when you talk about, you know, your structure, the matrix of data that ultimately sits somewhere, you know, it's an individual record, and you're just kind of trying to match it all up, and then use that, you know, and then how much out of sample prediction are you doing to, you know, create your little health risk scores?
So kind of all of the above, except that we can't just go and request somebody's medical records without having an authorization from an entity that actually have the rights to those records. So my example was an insurance company. We don't work with any insurance company in the state directly, but work, let's say, with an employer that then authorizes us to go to that insurance company and ask them for the records. Work with some other insurance companies outside the state that came to us and said, well, our trend, basically our healthcare costs are going up and up and up, and all this wellness companies coming, and we're doing everything that they say. Consultants are coming, and they should have been paying us by now because they've predicted that we're going to save 20, 50, 60%, but it's just not happening. So what can we do? So we take them their data, we analyze, and we make those predictions based on the data points, right? So based on the data that we aggregate. So that gives us the right to do it because we contract with an entity that either have rights or already are storing the data. So we can't just come in and say, I want to get your medical records.
You have to do the legwork, right? So
we have to do all the
they
legwork,
don't do the
correct.
legwork for you. You have to go.
No, and sometimes in the politics, the way it works is carrier, like a large insurance company, would not want to release the data, but their customers do want them to release the data. So we're kind of, then we have to do a lot of the political maneuvering and working with all the entities, connecting with them. So I think that's probably the most difficult task. And
Yeah, and to this kind of the second part of your question, like how do we store this and link it together? And that's another huge challenge that we're dealing with every day, is that if you can imagine, we're getting claims from multiple different insurance companies. We're getting health risk assessments from multiple different vendors. So we're getting everything in a different format and a different file type. And so that's a huge part of what we do, is then normalizing that data so that we can use it and you know, make meaningful predictions with it. But we're able to, a lot of the claims data it's the same stuff, but it'll come in a different format, so we can kind of cross map it to our format. The health risk assessment, we're sort of able to cherry pick the questions that we know we need. But it's still, you know, we're getting everything's coming in a different format. And, you know, we're looking at, like, there's two different types of diagnosis codes, ICD-9 and ICD-10. So we're looking at making sure that when that happens, which was supposed to happen this year and is not, but that we're also able to keep our tables and all of our updated importing procedures so that we're able to keep those claims coming in and change over to new formats and stuff like that.
I think just to give you an idea, you mentioned ICD-10, I'm glad. The world is moving to ICD-11. So what is it, 5 years into talking about switching to ICD-10, we're still talking about switching to ICD-10, and that has been postponed, I think, 3 times by now. So.
At least 3 times.
Yes.
And ICD is what?
It's a common diagnosis, the international common diagnosis. So
Codes.
yeah, it's a diagnosis
International
code.
standard.
And just to give an idea, so if we're on a version 9 right now, which has I think about 17,000 unique diagnoses, with the ICD-10, so with the version 10, it'll go to 120,000. With ICD-11, it will be even greater. I guess we haven't researched the version 11, but that's the assumption. They're just going to become so more accurate, and basically saying, if you got an injury, was it an injury while you're playing tennis, or was it where you're riding a bike, or you're sitting at your desk, right, and got a paper cut? So all those would be then identified. So, but with that, as you can imagine, it's just so much more data to mine too. So it's a good and it's bad. In terms of linking the data, the best positive ID is Social Security, but we can't use it. So now we have to create others. So
you have unique numbers for everything.
Correct.
You probably don't even have names, right?
Depends on what we do. One of the HIPAA provisions is that we only are allowed to look and release and work with the minimum required data set. So if we don't need names, then we don't release them, we don't obtain them. If we do need names, then we do obtain them. So
Yeah, and typically we're trying to identify people for case management, so we will get a name.
Yeah, I guess you would have to cross those different.
a phone number most of the time is the most valuable data point, because if you know somebody is at risk for something, now try to reach them. Sending a letter might be too late.
So, and when you're doing your predictions, are you limited to just say, oh, this is the employer that hired us, we can only look at their data, or do you get to put everybody's data in a big pool to try and do your prediction? And if so, how many people do you have?
We have millions of covered lives, different data sets, like whether it's a demographic, like the census data versus medical versus pharmacy claims. They have different numbers. For instance, on the pharmacy claims, I think we're close to 1 billion of pharmacy claims records. So it's a claim.
Those are the claims, right?
Those are the claims. There'll be several million people, right? And some of them were, let's say, just in one-time data that we might have purchased somewhere. The ones that we receive on a continuous basis. So we look at them kind of across, and then the data modeling. One of the challenges for our research and development team is to mitigate, to bridge any data gaps, right? So, like, let's say if we're looking at non-claims data, which again it's relatively new, so it doesn't exist as much out there. But if you can start with 1 million people, by the time it gets I want to get the health, self-reported data, the biometrics lab, that pool might have shrunk 3 times, So having everybody with those data points.
Do you use non-claims data that's not health data, like consumer data? And do you have a relationship with consumer data brokers, that kind of stuff?
We are looking at it, correct? And then actually next week we have a meeting our research and development team. So there has been shown big correlation, let's say, between even something as basic as your zip code. So your zip code, and let's say not necessarily how ill you are, but how you're going to be behaving once you enter a healthcare system. So you might have exactly the same diagnosis as somebody from another zip, but the way that you're going to be consuming healthcare will be totally different. So we're looking at that. Sometimes they're, we're also looking, I guess, at credit scores. Could be a big, huge predictors. So all those, yes, we're entering that area too.
Do you have environmental data?
Like
air quality, or
no, but it is. I was exposed to. Funny that you asked too. Is I don't know if you know, ISO is one big. They became Verisk Analytics, and we work with them too. So they work in healthcare, in the insurance, and the banking industries. One of their biggest researches, kind of the new coming up, is looking at patterns of consumer behavior, which again, healthcare behavior is part of the consumer behavior, and weather patterns. So, which can also then be influenced. So, no, as a company, we haven't entered that, but there is an area of the research that's looking into it. We haven't done that yet.
Has the HIPAA stuff made a difference in terms of the, sort of choices you make about hardware and whether you have to host stuff, or you can,
Yep.
yeah, so can you talk about that?
Yeah, it does. So compliance costs have added, huge costs to doing business. So to have a full, and it's not just HIPAA, there is also, there something as, you might have think something as remote as Sarbanes-Oxley Act.
No.
So, right, yep. So basically, if we're making decisions that are impacting financial well-being of a company, then we need to comply with some provisions, and there are audit standards. There are different types of audit standards. So something as basic as hosting and who has access to the data sets also dictate where we host our data sets. So we do have a couple publicly traded companies. So by the time that they're ready to make to make decisions that will impact their financial statements, and we need to move all of our production into fully compliant with Sarbanes-Oxley Act. And then as far as HIPAA compliance, that goes without saying. So we're always, so all the machines are encrypted, password protected, so all those
So does that
put in
mean
place.
that you purchase and host the hardware at your site, or does it just mean that you do business with vendors who certify that they comply?
We like the latter. So started with hosting ourselves, but it's just the price of compliance and keeping it up and running has been more unbearable. So all updates and upgrades and the compliance would rather outsource it.
Does the FDA have quite a bit of an impact on that, on your compliance?
Yes. So the cost, so just from the cost, so let's say what Sarbanes-Oxley, a non-compliant vendor will probably come at about 50% less price than a fully compliant vendor. So, and then for us to do full compliance and maintenance, then we have basically hire a person that will do nothing more than just that function. So I hope we grow to the size when we need to hire a couple of people like that. But it seems like moving things into a cloud is a lot better.
No, but I meant the FDA, the Federal Drug Administration. They affect you quite a bit because there's a lot of compliance work.
Right, so there is a lot of compliance, and of course anybody who touches a personal health record are subject to audits, so by Department of Labor, and I don't know, I think they might have outsourced to IRS or Health and Human Services. So, but there are HIPAA audits that can basically knock on our door at any point and do a full audit.
Yeah, and it's interesting, with security, it's like, well, we don't have wireless. We don't have any wireless in our office. We have our own firewall. But, with hosting a server, it's like you have to have physical security of that server as well. Like you could have as many firewalls as you want, but if somebody could break a window and steal your server, you're screwed. So there's a lot of aspects to security besides just the hardware. It's like your physical security is going to be a huge issue as well with that. Yeah.
How do you deal with the internal aspects of the broad diversity of data you guys have? What about employees going in and looking at their neighbor? How do you, that's part of the auditing compliance, I'm sure, but how do you guys deal with it?
All right, so that's, well, first of all, it's through contractual work that that we do with our employees. So they're bound by things that they sign internally. We also do audit trails. Which databases that you have access. Not everybody have access to all the databases. So as I mentioned, minimum required. If you're a database administrator, and you work on it, most likely you have access to most of the data sets that we have. So it's primarily, as I mentioned, through either limiting the physical access, auditing, or making sure that we make our employees sign confidentiality.
Yeah, and that goes back to being, HIPAA. We're basically on the same level as a doctor with access we have. So as an employee of DataSmart, well, it's possible I could stumble across my neighbor's data, but at no point would I ever be able to disclose that. And it's just as like a doctor, if you have a patient that's a good friend, you know them, you can't talk about them outside of work. So it's the HIPAAs, that's it. You can't talk about it, that's the rules.
I think a lot of those concerns have been further highlighted by NSA revelation, things that have happened, just things that have been leaked. So definitely a concern and a point that we take, very seriously.
How much internet do you get into your building, and is it affordable? We've been having this conversation about broadband pricing and availability, and it sounds like if you're hosting stuff off-site and you're moving data sets
Oh, yeah.
back and forth,
Very,
how's that
very
working for
important.
you?
Well, I think we're very happy to be in this building. I think we have the fastest internet in the world, probably. So right, and if it's and if we see something takes a while to load, then probably we can say, I think your website is slow. It's not us.
Yeah.
So anyway, it's been wonderful. But
Yeah, we've been lucky to get this data connection here
Right.
on Tech.
Yeah. How long have you been in the building here?
Three
February?
months, 4 months, yeah.
Cool. Was that an attractant? The
Yeah,
data?
absolutely.
Yeah.
Cool.
So how big is data center here?
Well, we for a while we went through a period when we couldn't hire fast enough. So literally from a company of 2 people, we went to a company of 12 people now. So and that's you can imagine the growth like in a matter of 3 months. So we stopped our hiring right now. Want to stabilize our pool of employees and kind of our processes, and then hopefully leap forward from that. So.
Yeah, we moved into Montech. We had 3 employees in our little office, and we're up to 6 now.
Just here. So and then we also have Helena office. So.
The other 6 are in Helena?
Correct. Yes.
Do you have like different, what do you do over here versus what do you do
Yes.
in Helena?
Yeah, so most of the analytics is done here out of Missoula. Most of the data normalization, data loads is done out of Helena. Plus, we have clinical team in Helena, and in Missoula, we also we formed our research and development team. So they're throughout different campuses. So mainly, so we have a person that we're working with very closely out of Kalispell. A person that is actually in the Bitterroot, so we work with that person, and also one here at the U of M.
So what is your internet connection like in Helena? Is it as good as?
Well, for a while it was very bad until we switched and we upgraded. So I think they have T1 line, or I don't know. So it seems to be non-issue presently. So, but for a while, again, it's kind of how can you project your the volume of the data that you'll be moving. So, and then trying to update this and try to identify where the issue is. Is it your hardware? Is it the connection? So by the time we resolve it, probably took us a couple of months, kind of just to troubleshoot to get the best flow. So, but now it seems to be working. So. Yes.
Are you able to share who any of your clients are in the state at this time?
Yeah, so some.
Healthcare facilities.
Well, so yeah, so we have long working relation with the university system. We also work with a couple coalitions that provide insurance benefits. So Montana Bankers Association, so just some of them. And then, of course, outside the state, our client base is pretty national. We work with healthcare providers, hospitals in Wyoming, and then also, along the coastal areas. So there are some as well. Having a lot of data also allows us to develop products. So product in our mind, like our own health risk assessment, there will be some our own product, but also networks of value-based providers. Like, let's say we're only gonna bring you into a network if you show a value of what you do. And so we love working with primary care doctors because in our mind they're underappreciated, underpaid. But I think a lot of the outcomes are actually dependent on how primary care doctors do. So.
How are you funded?
Oh, go ahead.
How are you funded?
We are funded through our clients, so by charging fees, yes.
Organically growing.
Primarily, right. So we do have some funding secured, kind of more as a line of credit. So, but primarily we kind of try to pull our own weight. hopefully.
Did you start with sort of like government grants and stuff, and kind of?
We did not. It was privately funded. So we've been able to repay some of the previous investments, and like I said, now our goal is kind of to start pulling our own weight. So, but you know, as I mentioned, kind of with expansion even of our employees base, you know, I would say 80% of our expenses goes to wages. So because we're just in all of it is intellectual capital, kind of, you know, so all the people base. So and having the right people. I mean, you have to pay them good wages. So
who do you hire? Where did they come from? And how hard was it to get them?
Initially, it was kind of a pool of friends and colleagues. I mean, I've been in the industry for 15 years, and kind of, you know, you get to create connections. Some other partners that are in the firm that they've been even for longer. So kind of we brought people that we knew. We also had hired a couple new guys too. So, but yes, it is very hard to hire right people. There is a competition. Even I guess the supply is rather low. You know, of people that work within the specific industry here. I mean, if you go to Spokane or Seattle, you know, not, you know, even to those places, and not like even the coastal, you know, more kind of major hubs of healthcare. There are even more there. So we get a lot of interest working remotely for us. So far, we primarily for kind of the key function is only the local ones that we would hire. So,
yeah, we've had really good success with pulling people out of the Missoula College who have graduated with the associate's computer science degree and have taken SQL classes there and healthcare informatics classes through the Missoula College. So we've been hiring within state. We haven't pulled anybody from out of state. We're pretty savvy with getting people who want to stay in state, who are from in state, and who are motivated and interested in, you know, getting involved in kind of the early phase of Data Smart and being able to see it grow. So
yeah, I think it's kind of it's unfortunate. I mean, I graduated from the University of Montana local campus, and I don't think I had a single class on either insurance or healthcare. And, you know, it's such a big part of our economy. So people coming in, if they've taken any healthcare informatics classes, they might know some stuff. And it's really interesting to talk. We have one guy. One of his senior projects was to create fake healthcare records. So we came and like, well, here's 1 billion of actual records. So it's really interesting. So, but yeah, I mean, most people they come in, they don't think it's appealing, but once you start explaining and they learn more, it's like, oh, we didn't even know about it. So. Yes.
How much training does it take to get an employee up to where they're productive?
Well, with Jordan, it took about maybe 2 days, and he hit the ground running. But normally, it's probably anywhere from 6 months to 2 years. So you have to make commitment, investment, and a good point is starting to work with local college, so College of Technology. Bringing people in, training them, you know, doing the internship. It's a great way to introduce them to what we do, how we do. I mean, we're still a small office, but we don't really expect them to start grasping till probably 6 months later. So they can do things, but they don't know why they're doing them yet. So.
Yeah, we give people a pretty quick crash course, and we don't try to train people in Excel or SQL. We try to find people who can teach themselves.
Hopefully they graduate with that knowledge too.
and I know that my skills just working here have increased exponentially in SQL and in Excel as well. And yeah, we'll give people like some pretty tricky spreadsheets and SQL queries to work through. And the first time they do it, it'll take them a week or 2 weeks. And second time they do it, it'll take them a week. And then the third time they do it, it'll be like 3 days. And then we get them down to the point where it's like you can do that in a couple hours. So. Just, yeah, working through it and working with our templates and procedures and learning the languages and stuff like that.
But it's been wonderful. Every time you bring a new person on, I mean, it's a two-way street, so we're learning as much from them too. So.
How many people do you have that are really doing the kind of industrial strength analytics, the SAS and all that?
So we have we have 2 people that are doing kind of very heavy-duty research and development work. We have 1 person that is kind of more policy guy. So so far, it's been pretty good. So it seems like if 2 people can do the work, it just means that they don't have the right tools and the right setup. So then kind of we'll go back and say, well, let's revisit. What do you use? What else do you need? So. All right. Well, thank you guys for listening. So.
Very interesting.